Okay, guys, let's get into Chapter 9, laser safety. I did want to point out here there's a great ACRAC podcast on laser safety. If you'd like to listen to it, hop on to the website there, and it's episode 174. Okay, some of the laser basics to understand. So, the first thing is that lasers differ from common light in that lasers emit a more focused beam. And because of that, that provides a number of advantages to surgeons using it as a dissecting tool. It can cut clean and precise, it can cut from a distance, and it can cut with depth control. The depth depends on the kind of laser that's used. And of course, what kind of laser, every kind of laser requires safety precautions, but based on the type of laser, will depend on specifically what type of precautions that you take. So most importantly is the eyes. And so whenever you're doing these cases, all goggles will be distributed in the operating room for anyone that's going to be in the operating room during the case while the laser is being used. So based on the kind of laser, dictates what PPE you need. So CO2 lasers are known to cause injury to corneas, and as a result, these clear plastic lenses are adequate to protect your eyes. However, the argon and YAG, they can actually burn the retina. So a different type of lens is needed. For argon, you need this amber orange filter, whereas on the YAG, you need the green tinted filter. Again, when you do these cases, you will be provided with these goggles. Other eye safety practices, you never want to look directly at the laser. And then, of course, you don't want to keep any reflective objects close to the field of laser such that, potentially the beams can then, penetrate your eyes from a different trajectory. So this is just a nice schematic that talks about safety precautions when using lasers. Eye protection, which we just went over, fire safety, which we'll get into here in a minute, and then general safety. So when you're doing these cases, what you'll see is there's restricted traffic in the operating room during the laser procedures. That the circulator will generally cover the windows on the operating room doors. They'll post laser warning signs on the outside of the doors, and they'll actually hang goggles on the doors so that if someone needs to come in, they can protect their eyes. So let's get into fire safety. That's another really big part of laser safety, and a very popular board question. So remember that the three components leading to a fire in the operating room are oxidizers, which can definitely come from our ventilator with supplemental oxygen and nitrous in particular, an ignition source. So remember that's generally a BOVI or a laser. And then a fuel source. And, that can be the drapes, that can be your endotracheal tube, anything that will burn quickly. So first of all, let's talk about preventing airway fires. Let's talk about fuel source. If you are using a laser in the airway, there are very specific types of laser endotracheal tubes that are safer than our standard PVC endotracheal tubes. However, the protection is not, it doesn't completely eliminate the possibility of fire, but it does reduce. Also, you should inflate the endotracheal tube cuff with water rather than air whenever possible for laser surgery. And some of these tubes actually, the laser safe tubes, they actually have methylene blue in the cuff so that should the cuff rupture, you can see the blue leaching out. Some other things about preventing airway fires, you never want to use paper drapes or have dry sponges. So all the sponges that you have in the surgical field should be soaked with normal saline. All right, oxidizer, again, Avoid use of high concentration of oxygen and nitrous. Helium, which is used in some centers in the form of heliox, is a more inert gas and is less likely to be combustible. This is a great schematic put out by the Anesthesia Patient Safety Foundation, the APSF, about the prevention of fires in the operating room. Do keep in mind the most common scenario for a fire in the operating room occurs in patients receiving MAC, so monitored anesthesia care, when they are having surgery of the head and neck. The combination of those two factors is the most common scenario for a surgical fire in the operating room. So let's start at the top here and just walk through this real quick. Is the patient at risk for a surgical fire? And if it's yes, then one of the things you can do to help prevention, nurses and surgeons should avoid pooling of the alcohol-based skin prep and make sure that it's allowed time to dry. Communication between surgery and anesthesia prior to the initial use of electrocautery. So, very commonly this is discussed at the timeout. Let's move on down here. Does the patient require supplemental oxygen? If they do, thinking about a MAC case, you can see how it would the oxygen could potentially be dispersed into a surgical field. And if it is of the head and neck, how it sort of saturates the surgical field given the close proximity. And the recommendations here, if you do need greater than 30% O2 concentration, then you should potentially consider actually establishing, putting in an endotracheal tube or a subglottic device to, again, reduce the amount of oxygen that's being dispersed into the surgical field. All right, so we talked about prevention. Let's talk about when a fire occurs. And when you think about this, you need to think of two different scenarios. The first one is when a fire occurs in a surgical field, okay? So let's say you're in the operating room, you see smoke in the surgical field. The first thing you want to do is stop the flow of airway gases, have the materials removed from the patient, extinguish the fire by pouring normal saline. If that is not successful, you want to move on to a CO2 fire extinguisher. If that's not successful, you want to activate fire alarms, remove the patient from the operating room, close the operating room door, turn off the gas supply to the operating room. Now, again, this is going to take a team effort. You're going to call for help, and it's going to take a number of people in a concerted effort to do this quickly and efficiently. Now, the other thing you want to consider is if the patient doesn't have an established airway at this point, you want to evaluate them for injury to the airway and consider intubation. And, you're going to have to, if you are concerned about injury to the airway, then you definitely want to establish, place an endotracheal tube sooner rather than later, because as time progresses, you're going to get more edema. All right, so we talked about if a fire were to occur in a surgical field. Well, what about when a fire occurs in an airway? There are very specific steps that you need to take as the anesthesiologist. And again, you're going to be the expert in the room should this occur. The first thing you want to do is remove the endotracheal tube. Very counterintuitive to a lot of us, but it is the recommendation. After that, you want to stop the flow of all airway gases, remove sponges or other flammable material, pour normal saline into the airway, and then you want to reestablish ventilation with an endotracheal tube. The thing you really want to consider here is that the anatomy at this point may be very altered, and you may have edema. And as a result, it may make this far more difficult to access the airway. So call for help, get a bronchoscope in the room if you need it, get a glide scope in the room if you need it, and proceed with caution. After you reestablish the airway, you want to examine the damaged endotracheal tube to see if the remnants are all there, or potentially are they in the airway? And if they are, you want to consider bronchoscopy. Okay, so another thing that you want to consider when using lasers in the operating room. They are very commonly used for multiple lesions of human papillomavirus. And as a result, that can create a situation where there's particulate contamination in the air in the operating room. And as a result, recommendations are made to use smoke evacuators and laser surgical mask. Gloves, anti-splash, eye protection, and masks should always be worn during laser surgeries. But in particular, if they are lasering some of these lesions, you need to think about the inhalational component of that. Okay, let's go on to the questions here. Risk for airway fire during laser resection of a tracheal tumor is decreased in, okay, A, CO2 rather than a GAD laser, B, helium greater than 60%, C, nitrous greater than 60%, or D, PVC endotracheal tube, E, halothane mixture. All right, so first of all, let's look at, so we know that C is incorrect, right? Because we know that this is, nitrous is very combustible. We've been talking about that. We know that the standard PVC endotracheal tube can catch fire very easily, so it's not that one. Halothane mixture, what they want you to really gather from that is there's a good bit of oxygen in the mixture as well. So that's not a good answer. CO2 rather than GAD laser, there's not really any difference between the two of those. But the real thing to know here is that, again, helium is a very inert gas. And as a result, if it has a high concentration of it, it's probably the best thing that you could do to decrease the risk of airway fire. So the answer is B. Okay. Question 2, reduction of airway fire during laser surgery of airway best accomplished by use of, okay, this is very, very similar to question 1, continuous mode laser emissions, nitrous oxide opiate relaxant, PVC endotracheal tube and cuff, D, topical lido, E, saline filled sponges over exposed tissue. Okay, so we talked about this a good bit. Again, saline filled sponges over the exposed tissue is the best way to reduce the risk of airway fire. The rest of these, we've topical lido has no bearing. These other two we've talked about, and continuous mode, you can imagine you just have a common source of ignition. So, all right, question 3, laser safety eye protection for the OR staff is needed. Clear wraparound goggles are adequate for what kind of laser? So the clear ones are, again, this is just kind of rote memorization, but it might be easy to remember because clear goes with CO2. Those are both C's. Okay, so the answer here is C, clear wraparound or CO2. Question 4, during laser microsurgery of the larynx with endotracheal tube, fire occurs in the airway. What's the most appropriate initial management? Okay, we talked about this. And again, when it's of the airway, removal of the endotracheal tube is the first thing that you want to do. A lot of folks like to decrease the FiO2, saline it into the endotracheal tube. Remember, the first thing that's recommended is removal of the endotracheal tube. All right, that's all on laser safety.